Hello and welcome to the first in our Arthritis Ireland conversation series, Living with Rheumatoid Arthritis. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. Our mission in this series is to bring you up-to-date information on a range of arthritis conditions. During these episodes, you will hear from expert voices from across the medical spectrum as we strive to answer some of the more common questions you may have and to gain some insight into the latest medical research relating to these conditions. Today I am joined by Dr Carmel Silke, Consultant Rheumatologist at the North-West Rheumatology Unit based in Manorhamilton. Carmel will offer insight into the importance of early diagnosis of rheumatoid arthritis, the signs and symptoms we should be looking for, and the medical and lifestyle interventions which can help people to manage the disease. So Carmel, thank you so much for joining us here today. Delighted to have you.
Thank you.
So my first question, I guess, for you is, what exactly is rheumatoid arthritis?
Okay, well, rheumatoid arthritis is a type of arthritis that's linked with the immune system. So we've all heard about osteoarthritis and arthritis that older people get, and that's often due to wear and tear. So that's not what we're talking about today. So for example, if you had an old injury when you were a young person and injured your knee, got a skiing accident, that might lead to arthritis, and that's the osteoarthritis. Okay, so what we're talking about is the immune system. People often describe it as it's like the immune system attacking your joints. Now, I don't always like that term, but sometimes it's a way to explain it. And for some reason, we're not quite sure why. Maybe it's a combination of genetics, the environment, but for some reason, something triggers the immune system and you start to get painful, swollen joints. And that's linked to an inflammatory arthritis. So there's lots of different types. Some people say there's 100 types of arthritis. I haven't added them all up myself, but if you go through it, there's the wear and tear arthritis, there's gout, all of those different types. So rheumatoid is a certain pattern. So it affects often the small joints, the hands, the feet. It's often, we describe it as symmetrical, which means it's affecting the left side and the right side reasonably equally. Now, sometimes it can start with just one side. It can maybe start in the knee and then, but generally in most people it affects both sides reasonably equally, and often the small joints more than the large joints. An inflammatory arthritis is probably a little different than the degenerative arthritis, is also in the way it presents. So often it comes on sort of gradually, maybe over a few weeks, and a patient might notice that they've hot, swollen joints, often worse in the morning, and morning stiffness is a very common feature with it, often for over half an hour and some people for many hours. And that can be very difficult and then may get better as the day goes on. And that's another difference from the more degenerative arthritis somebody might get from an old injury or wear and tear as they get older, where it's often just worse on activity or later in the day. So they're just some of the ways that we try and separate which type.
And you've mentioned there some of the signs and symptoms that, can accompany, rheumatoid arthritis. Can you tell us a little bit more? So you've mentioned kind of hot, swollen joints. Are there other things that
Yeah, so that's right. So often hot, swollen joints is a very common feature, and when we get a referral letter, that's something that prompts us to think that this is something that should be seen quite urgently, and I'll come back to that again in a few minutes. But swelling, soft swelling, not hard bony swelling, that's come on reasonably recently. So if somebody had a swelling maybe in a finger that has been there for 5 years, that's probably less relevant than a hot swollen finger in the last few weeks. Stiffness, as I mentioned, early morning stiffness for half an hour or longer is the other common features. But people might also have other non-joint related features like fatigue, tiredness, lack of energy, feeling generally unwell. And on some occasions they may have weight loss and just feeling just not themselves. But generally the fatigue, joint pain and swelling would be the more common symptoms.
Okay. And can you tell me how important early diagnosis is?
Yeah, it's so important, and we've learned that in recent years, and I suppose in a positive way it's so important because we can do something about it. So when we get a referral letter for a rheumatoid arthritis patient, we try and see them as quickly as possible, because we know the quicker we see them and the quicker we get patients on treatment, the more likely we'll get them into what's called remission. And remission means, like we're used to remission in cancer,
Yes,
but say for rheumatoid, we're talking about getting into a place where the arthritis isn't causing them problems, isn't causing damage, isn't causing joint destruction, and all that's possible with early treatment. Now, don't worry if you haven't been caught as early as you like, because there's many problems with getting people seen early, and I think we're all well aware of the long waiting lists. However, when we get a referral, we do, if it's clear on the referral letter that this looks like a rheumatoid arthritis, we should, and we do try and get those patients seen as early as possible. There is some hope that very early treatment might lead to cure, but the evidence isn't strong there yet. So really what we're aiming for is remission, where with treatment, the arthritis isn't causing damage. And it's all about preventing damage, preventing joint destruction, like we used to get years ago. So if someone is diagnosed with rheumatoid arthritis in 2023 or in it's less of a problem than it was 20 years ago when we had much less treatments. So we're very optimistic with early treatment. We can do
that's really positive. That's really positive news for people. When it comes to diagnosis, can you tell us a little bit about how that diagnosis is arrived at?
Okay, so generally when the patient comes to us, the GP will have done certain tests, and the GP can do blood tests for inflammation, and they're often very high in patients with rheumatoid arthritis. Not always. So if they're not high, it doesn't mean it isn't rheumatoid, but if they are high, it's helpful. They will often do a blood test called a rheumatoid factor and a CCP antibody, and they're just blood tests that GP can do in their surgery. If they're positive, particularly the rheumatoid factor, it doesn't mean it's rheumatoid, it just might be slightly more likely. And then the other blood test is more specific. But in generally, a combination of those things, the blood tests and the symptoms and signs, make it strongly suggestive that this could be rheumatoid if it all fits. And then we'll often do x-rays, and then the x-rays are looking for any early changes, any signs of damage on the x-rays. But generally it's a very clinical diagnosis, and it's a combination of the blood tests and the presentation of the patient. So I suppose I don't want patients to worry if they've heard they have a positive rheumatoid blood test. That doesn't mean they have rheumatoid arthritis. It's only relevant if all the other features are present too. And sometimes that can cause concern. So it's really the symptoms that are the most important thing, supported by the blood tests.
Okay, and equally we sometimes hear from people who are seronegative. Can you tell us a little bit about what that exactly is, what that test is, and what that can mean for somebody that's seronegative?
Yes, and that can be very difficult, and that can sometimes lead to slightly later diagnosis. So what that means is that the blood test for the rheumatoid factor is often negative, or the other blood test I mentioned, the CCP antibody. So if they're negative, that patient may still have rheumatoid, particularly if all the symptoms I mentioned earlier, but it may not show up in the blood test in that sense, and they can still have rheumatoid arthritis, just as serious, not always as serious, but it can go on to cause all the same problems. So it's important that patient is treated as well. It just means that the GP and the rheumatologist will need to use all the other factors in making that diagnosis, and can make it a little bit trickier to make, but can still be med. It does sometimes have an influence on what treatments are used. So that whenever we have a patient who's not doing well on a certain treatment, we'll often go back and look to see, are they seronegative? And in which case that might influence which types of treatment we use, because some of the science that's been done has shown that certain drugs work better in seropositive patients rather than seronegative patients.
Okay, and that nicely leads me on to my next question in terms of when a patient is diagnosed, just in terms of getting the disease under control, what type of treatments are usually considered? And can you take us through kind of, obviously there's been huge developments in the last sort of 20, 25 years in this whole area. Can you walk us through those treatments and what might be considered for people at different junctures?
Okay, so we're so lucky now. There's so many options compared to when I started many years ago. It really has changed. So I suppose there's a couple of ways of looking at it. One is treating symptoms, and this may have already been done by the GP, and that's a combination of painkillers, anti-inflammatories, and maybe steroids. And I think we're all aware steroids have possible long-term side effects, but sometimes they're very necessary in the acute situation. They have a role, and they're really, really helpful at reducing inflammation in the short term. And these aren't a long-term solution for most patients, but in the short term they often do help. So often that can be done. So anti-inflammatories, painkillers, steroids are the short-term plan, and may be used for bridging between treatments. But in a more definitive treatment, and by that what I mean is something that we might hope will prevent damage We use this group of drugs you may have heard of called DMARDs. That stands for disease modifying anti-rheumatic drugs.
Yeah.
But what that really means is drugs that will hopefully prevent damage. And those drugs are methotrexate is the most commonly used ones. Now, some patients are worried when they hear of methotrexate.
Yes.
They hear, because they may have read about it or heard somebody else on it. So methotrexate has been used for other reasons, say cancer treatments and different things. So the way we use it is in much lower doses. And so we don't necessarily get all the same side effects that somebody would get who's on it for other treatments. So for rheumatoid, methotrexate either is a tablet or an injection. Once a week is generally our first treatment, and we often use folic acid alongside it. Now, we do sometimes consider other options. For example, if it's a young woman who's maybe about to have a baby or planning a baby or a pregnancy, we might look at different options because that would not be suitable for someone planning a pregnancy. But we have other DMARDs, those disease-modifying drugs. Quite a few options that we would often use at the beginning, like sulfasalazine or silazapyrin, hydroxychloroquine, Plaquenil, leflunomide or Arava are often very commonly used DMARDs.
Yeah.
Now,
And can I ask you just on that, in terms of methotrexate being available as a subcut injection or a tablet, what considerations are there in terms of choosing whether somebody takes it orally or by injection?
Okay, so we used to use it orally all the time, and then we went through a phase of maybe using the injection form. And now we've gone back to oral. And the reason, I suppose, why we've been changing is a lot of patients have side effects. Not all, some patients have side effects, and often there can be nausea. Yes. So if somebody has significant nausea with methotrexate, the injectable form generally causes less nausea, and that makes it much more a better experience for the patient to take. Yeah. The other reason we might use it sometimes if the efficacy isn't quite as good as we would like, or if the patient maybe had malabsorption, they weren't absorbing tablets as well as we would like them to do so. Given the injectable form might just give a little bit more benefit to the patient, a slightly higher dose. We did a little study to see, did it make a difference? Starting at first line, we didn't find a big difference, so we've gone back to using the oral version for patients and then just changing it to the injectable version if they have side effects or a patient preference. There's a small cost difference, so that can sometimes be a factor that patients, methotrexate tablets aren't very expensive for patients who have to pay, and the injection is a little bit more, so sometimes that's something that does influence patients' choice.
Okay, so moving on from the DMARDs then, what other treatments might be considered?
Yeah. So we're very fortunate in Ireland, we've really good access to the biologic treatments. So what the biologics in general are, they've discovered when researching what causes rheumatoid, there's all these different molecules, and the immune system is so complex, there's so many different molecules. And there's some different names you may have heard of, TNF, IL-6, IL-1, they're all different molecules that cause inflammation. So in some patients, TNF might be the main driver. Some patients, it might be a different molecule. And all the biologics are is different drugs to target those molecules. Some people call them immunosuppressives. And in a sense, some patients that can affect the immune system, but I don't really like using that term for most patients because it's only really affecting a small bit of the immune system. And the immune system has so many parts that are working away as normal, so most patients don't have any problems when they go on these biologics with the immune system. So the most commonly used ones and that people will use are the anti-TNF biologics. So these are drugs like etanercept, adalimumab, golimumab, certolizumab. I'm going to have to be careful now I don't forget what. And they're the anti-TNFs are like the most commonly used ones, and we've biosimilars of some of those now. So we're very, very fortunate. So what they do is they target one of those molecules. And then we have other ones that target the IL-6 and other ones that target different molecules and others that target B cells. So we've lots of different options there. And what they do is we use those when the DMARDs aren't working. And they are very expensive, but we're very lucky in Ireland that either patients can get them through the medical card or if they don't have a medical card through the drug payment scheme. And so really most people do have access to them. Mainly they're in an injectable form every 2 weeks or every week or every month, but there are some that are still given as an infusion. Some are given, less frequently than that. So we often, when we're making a decision, we decide on practicalities, like what's best for the patient, how can they manage the injection. But we've been really impressed with how patients manage the injections. Sometimes they're really nervous and they're worried and think, I'm not going to be able to manage that, particularly if they've sore hands. But they're generally med for patients with rheumatoid arthritis, obviously med for patients with rheumatoid arthritis. So they try and take that into account. I really can think of 1 or 2 patients who had difficulty managing it out of hundreds and hundreds.
And the devices have improved certainly hugely, haven't they, in the last number of years?
Yeah, they've really done a good job in making them patient friendly. So often they're like a pen. So I think sometimes patients worry that they're going to have to inject like a nurse or a doctor would, but they're really med in pen, and they just literally can just do it very, very easily, and they're shown how to do it. And a nurse will often go to the house and show them how to do it as well as in the department. So we've lots of other options. Some of them then are, if that one doesn't work for the patient, we generally reassess after about 3 months. And if it's not working, we'll use a treat to target program where we'll tell a patient, we want to get your joint count, your swollen joints, your tender joints down to a certain number, as little as possible, and have you feeling better. And if you're not, we'll change it. So we don't stay with a drug that's not working. And if a patient's drug isn't working for them for the rheumatoid, we will change it. Now, sometimes patients might think it's not working, but they may have other reasons for pain. They might have a bit of wear and tear or something. So we have to tease that out sometimes. So it's not always as straightforward.
Yeah. And I suppose we're lucky that there are a growing range of options now to consider.
That's it. And that's really, really been exciting. And if the first choice that you use doesn't work, you might just change to a completely different mode of action. So I was talking about those cytokines a while ago. So if the one that targeted TNF didn't work, you might change to one that works in a different molecule entirely. And we've been really impressed how some of those work. And there's now tablet forms of biologics, the JAK inhibitors. So that's a whole different group of drugs that we've access to in recent years, so we're very, very, very fortunate.
Okay.
We don't know why. We're hoping, there's a load of research happening to see why does one drug work for one person and not for somebody else. And that's what we're really hoping that research will tell us, so that if somebody was to come to us with rheumatoid, we'll get the right drug first time. So sometimes we have to cycle through a few drugs. So I think if a patient has it, not to despair, to stay with it, but just let us know if it's not working. We'll change it again and again and again if we have to. And sometimes we go through 7 or 8 options, but we generally get there in the end.
Has research, to date provided evidence or enough evidence to I suppose give that information about what drugs are appropriate for certain RA patients?
Yeah, so
are we still at the point where we don't really know? We know a little bit, but we don't know enough to kind of recommend a certain treatment.
There's a load of work being done, and there is evidence emerging, but not enough yet to use in common clinical practice. What we do know is that going back to your earlier question about being seropositive or not, we know certain drugs work better in patients who are seropositive. So if somebody is seronegative, we might be slower to try 1 or 2 drugs in the first few rounds. And we might still consider them later on, but it might influence the order that we use the drugs for the patients.
Okay, yeah, that's really helpful. So moving on now to, I suppose, looking at when people receive that diagnosis and they're on treatment, it's fair to say that many people have struggled with accepting, that diagnosis, and that acceptance or that struggle can be, as much as dealing with their actual physical symptoms of the disease. Have you any advice for someone out there who is struggling, really to accept their diagnosis?
Yes, it can vary so much, and we don't see it coming, and it's often not clear to us at the time. But some patients it's the first time that they've been ill, they're worried, they've seen somebody elderly who may have had rheumatoid many years ago before there was treatment, so they're worried they're going to end up in the same way. So we really have to try and reassure patients that the chances of them ending up with significant deformities are significantly less than they used to be. I would always hope that somebody would talk to family members, and that the family members should be educated too. We're often very happy to bring in a family member when we're going through the information at the beginning. But also would encourage them to contact Arthritis Ireland. There's patient support groups, and then there's chronic pain programs for anyone who's got chronic pain. because they give really good advice about how to manage and cope with that, and lifestyle advice as well. But sort of just in general, without even going down those lines, is to give time to yourself, that this is something that you hadn't asked for. It's come on and it's there, but there is treatment for it that will work, and that to give yourself a chance. So do all the other things that make things easier for yourself. So like rest, avoid excessive alcohol, stress, talk to your GP if it's giving you ongoing concerns, talk to the family members and support groups. And the other things that help are like our exercise, which we might chat about again in a little bit, and just looking after your overall health will support everything else. And I think educating yourself as much as possible and knowing that this is a journey that you're going on, that it does have an end, this should become less of a problem in time, and that you're just going through the worst of it at the moment. And hopefully that might help people accept it. There was a lady, a nurse, did a research project with us who interviewed loads of patients and found that a lot of them felt it affected their self-worth. And a lot of patients found that they didn't feel that they were worried that they wouldn't be able to provide for their family, be a good mother, look after children. And I suppose I would hope that we can help support these patients and reassure them that all of those things should be completely fine. I often tell people, don't make a big life decision. Sometimes I've heard people maybe rethinking college courses for young adults who've been diagnosed. I really try and encourage them not to make a life decision just yet. Keep your options open. Don't leave certain courses out just because you've got rheumatoid arthritis, because bad and all as you're feeling at the moment, this will improve. So I suppose not taking major life decisions during a time of a new diagnosis would always be hopefully good advice, that they might defer any major life decisions.
Yeah, and in terms of, life decisions and life stages, we know that rheumatoid arthritis in the main, people receive their diagnosis when they're, younger. Maybe you might see it as they're in the prime of their lives, maybe, late 20s, early 30s, mid 30s. Can you talk to me a little bit about, that stage where people might be considering starting a family, for example, and just in terms of how their diagnosis of rheumatoid arthritis may impact that decision?
Yeah, so that's really important, because it is the most common time when people present. Like, we get people from all ages,
yes,
and obviously children to much older, but a common period is often in the postpartum period. 6 weeks after having a baby is a really common time to find people, but also just young women who may be planning a family. So there's a few different things to think about. One is, if you're arthritis, I'd always reassure them this won't affect them significantly in the long term, but just a few bits to consider. So if your arthritis is very active and your joints are very inflamed, your chances of conception are much lower. So your chances of actually being successful in having a pregnancy or becoming pregnant are reduced because of the active inflammation. So the first thing is to get your arthritis under control, and whatever is needed to do that, but to let your doctor know, because certain drugs like methotrexate, as we mentioned earlier, and certain other ones aren't safe during pregnancy. So if we know somebody is very serious, that they really want to become pregnant as soon as possible, we will then take that into consideration when we're deciding what treatments to give them. And we're very lucky we have certain options that are actually very safe during pregnancy. Often during pregnancy, the rheumatoid actually can improve, but not for every patient, but it can do. So we're often fortunate that it doesn't become a major issue during the pregnancy, and often certain simple treatments can help. But there are some biologics we're very happy to leave patients on, and certain DMARDs during pregnancy, but we need to know. And so we always say, look, that's fine, you'll be able to plan your family, just maybe wait till the arthritis is under good control, and then let us know so we can decide which medications we use. Because some of them you have to be off for a little bit of time, maybe 2 or 3 months before you become pregnant.
And just maybe another question there would be, obviously from the man's perspective, because men also get rheumatoid arthritis, what considerations need to be taken on board there?
Yeah, so I think also to discuss it with your doctor. Now, most of the drugs are fine for men planning a family, and if a lady was becoming pregnant whilst the man was taking certain drugs, that's generally okay. There was some concern with methotrexate, and the advice it does seem to be changing on that.
Yeah.
So up till very recently, we were advising men maybe to hold the methotrexate whilst planning a family, but that is beginning to change. So what I'm going to say here, because this maybe the timing of this may vary and the research is evolving, I think just discuss it with your doctor about what to do. But generally, the evidence is actually quite reassuring. If someone was to become pregnant whilst taking certain drugs, they should just talk to their GP about it, because there's certain, and their rheumatologist, because there's certain medications that can help increasing folic acid, folinic acid. There's different things that can be done, but that's something very important to just discuss with your doctor if it was unplanned.
Okay. And in terms of things like breastfeeding?
Yeah, so that's evolved, thankfully. So if we had this conversation a few years ago, we'd have been very anxious about what drugs you could take. There are certain drugs you can't take whilst breastfeeding, but a lot of the biologics now are actually safe during breastfeeding, because they've done studies and found the amount that passes into breast milk is very small. So we're much more reassured by certain drugs during breastfeeding. Check with your doctor, because there's one or two we don't have data on yet, and we're not as certain. So they will advise whether it's appropriate to do so or not, or to continue with the drug if you are breastfeeding.
Right. And you mentioned just there when we started discussing this that you see lots of women diagnosed with rheumatoid arthritis in the postpartum phase. Do we have any understanding about why that is? Why there's kind of a, if you like, a spike in people after the pregnancy? And obviously it's not for everybody, but certainly anecdotally I would have encountered lots of people who
so I'm not,
diagnosis.
Yeah, it's really interesting. We're not really sure, but it definitely points to the hormonal element in rheumatoid arthritis, because it is more common in women, we know that much, and it is more common in the premenopausal period of the first onset. We think it's due to the change in the hormone levels, and that often that during pregnancy it's nearly like a steroid, the hormone levels, it's nearly like acting a steroid on the body, and as a result the symptoms often improve, and then 6 weeks after, that big drop in the hormone levels is often when something that might have just been grumbling below the radar before becomes very, very obvious then. So I think that's my understanding of that.
Yeah. And how do you, I suppose, manage your patients in that postpartum phase? Because I always feel, in general, there's such a focus on the actual pregnancy, and then sometimes there's less of a focus after the baby arrives. But I can imagine that would be a very difficult time particularly for a woman with rheumatoid arthritis.
So difficult, and trying to hold the baby and things like that. So if there are a patient prior to the pregnancy, one of the things we'll generally try and do is we'll often schedule appointment for about 6 weeks after the baby is born. But that's a tricky time. You know, the baby might be due, lots of checkups and things, but we do schedule it so at least they have the option to come. But we also tell them that that's the time they really should, if they have stopped medication, they should really restart it. We generally advise them to restart the treatment if they have stopped it. Now, often they don't need to stop it now, but if they have stopped it, to restart it once wound healing has occurred, if they've had any wounds, and to get back on the treatment as soon as possible, particularly if they've had a history of flaring in previous pregnancies. With the biologics, one thing I didn't mention earlier was often they're allowed during pregnancy, but often we stop them in the 3rd trimester. For not all of them, certolizumab is allowed to continue right through. Many of the other ones stop in the 2nd trimester in slight variations.
Yes.
And the reason for that is just in case they affected the vaccination status of the baby afterwards. So if it was the case you needed to continue, that was fine. It just might mean the baby's vaccines might need to be delayed slightly. So it can be very individual. So I would suppose any patient who is pregnant or breastfeeding, link in with their doctor about what they're on.
Really, communication's key.
And often ringing hospitals, it's hard to get through. It can be very difficult. But if you have a number for the nurse specialist or ask to get through to the nurse specialist, they're often very, very good at giving advice for these periods.
Okay, great. Moving on now to, I suppose, the whole area of work and employment. So given that so many people who are diagnosed with rheumatoid arthritis are of working age, What kind of impact can RA have, on a person's professional life, their career, their employment possibilities?
Yeah, so we would encourage, in general, continuing working is for the best for the patient. So we would strongly encourage that, and think particularly in the last 15, 20 years, we'd really hope that most patients would be able to continue to work. They may have difficulties at the time of an acute flare, but they should be able to be managed. So I would really stress to the patients that they shouldn't change their career plans because of it, and they should be able to have a full and professional career as they wish to do so. There may be challenges like the flares, and really when someone has a severe flare, they may need to take some time or need some medications to help manage that during that period. Fatigue can be a big problem. So there's really good advice about pacing yourself and how to manage that. And often the occupational therapists are very good at giving advice on that. And there's certain things in the workplace that you may need to look at, any adjustments that might need to be made, particularly if you've had long-standing rheumatoid. So there's different things that some people find, not everybody, but some people find getting standing desks help, and it's not for others. Getting the chair and the computer at the right height. Sometimes they might need rest supports for typing. And for a lot of that, the occupational therapist will give very good advice of things that could be done. So I would encourage anyone to ask for an occupational therapy input if they're having difficulty, rather than any deciding they can't do it. A lot with adjustments, most things should be possible.
Yeah. You mentioned fatigue there as well, which kind of I wanted to come back to, because that's certainly one of the things I hear a huge amount from people that live with RA. Is this? It's kind of almost this unforeseen, not side effect, but impact of living with RA as well. How do you manage that with your patients?
So it's very difficult, and I suspect we're not very good at doing it. I suspect that we don't probably ask about it enough. We're so focused on the joints and the swelling and the stiffness, but it's overwhelming. And like you say, if you ask patients, that's one of their biggest problems. Pacing yourself is probably one of the main things. You often hear about the patient with rheumatoid who's having a good day, and then next thing they clean the whole house. So I try and say, look, even on the good day, we want you doing something every day. So on the good day, don't do everything you'd have done on the other 6 days. Do a small bit on each day, but don't put it all in. I do sometimes try and reassure patients, because sometimes the joints get better, but the fatigue doesn't. Often it follows on, and there's a lag. And I'm not sure of the evidence to support this, but often when the rheumatoid gets better, the fatigue persists for a period afterwards, but not necessarily forever. And it's like the fatigue, just it needs a bit of time to catch up. So you would be hopeful if the rheumatoid is better controlled, the fatigue will improve afterwards.
That's actually a really good thing to hear, because I've heard so many people say, well, my swelling is down, I'm being told that my disease is under control, but why do I feel so lousy still? So that's a really good point for people watching this.
I've seen, and but the time isn't as quick as you would like. It could be 6 months, it could be a year, but it does tend to improve after that, if everything else is right. Some people might get secondary fibromyalgia and poor sleep patterns, and if that's coexisting and they're not sleeping, or they're not exercising, or different things, they may get extra fatigue on top of that. Now you can do everything right and get it too, it can be very difficult.
And you mentioned exercise there, so that was one of my next questions about exercise and indeed diet. Can you talk to me a little bit about the role that they play in the management of RA as well?
Well, exercise, it's completely changed compared to years ago. Like, people years ago were told to rest, and we still want people to rest, obviously, but we want them to rest and exercise. And we know now that if you're exercising, your muscles stay strong, and then if they're strong, they support the joints. So the worst thing any of us can do is spend too long sitting, because then our muscles get weaker, and then we don't have the support for our joints. And even a few years ago, they were beginning to talk about, not even talking about how much you exercise, but how much time you spend sitting. And if you look at the amount of time you're sitting, if you just try and change that to be more active and less time sitting is the first step. And then exercise in so many ways. So say if you've got arthritis in your knees, the one thing that's been shown to prevent it getting worse from other than the biologics and treatments for any type of arthritis, even osteoarthritis, which maybe occurs secondary at a later stage, if you have strong quadriceps muscles, so thigh muscles, if they're strengthened, they're the one thing that's been shown to prevent that getting worse. And likewise in other joints, if the muscles are strong. But also if you're exercising, it affects your fatigue levels as well. So all of that has... Now, we don't want people to go out doing crazy stuff, so to pace themselves and gradually build it up. There's nothing that you shouldn't be able to do if it's paced and taken in steps, so one step at a time. So I know people who've run marathons who've rheumatoid arthritis. I don't know, I did a half marathon and somebody passed me by who I know has advanced rheumatoid and they were flying it. So all exercise is really important for strengthening the muscles, fatigue levels, energy levels and general well-being, and also for protecting against osteoporosis, which is often a secondary event with rheumatoid arthritis. With exercise, you want weight-bearing exercise to try and prevent that. Now, that doesn't mean you have to go lifting weights. You can just a short, brisk walk is actually more important than a long, leisurely stroll, because then you're actually stimulating the bone to form new bone.
Getting your heart rate up a little bit.
Getting the heart rate up a little bit, and that way you're actually having some impact on the joints. It's really important. Cycling is really good because it's non-weight based for other types of arthritis, or even a stationary bike. Often there's one at home. Swimming is excellent. Now, if you're a good swimmer, whatever you do is good. If you're not a strong swimmer, or if you're doing breaststroke with your head sticking up, up on the head under the water, that can aggravate a sore neck. So just look at your stroke, the way you're doing it, maybe get some advice. And if you really don't like swimming, aqua aerobics is really good.
But even walking in the pool, I've actually, it's something I've seen more of in the last while, which is, people actually walking up and down the pool. So you're getting the benefit of the buoyancy of the water. And it really helps your body. So even maybe wearing a pair of the water shoes or an old pair of runners or something like that and actually walking up and down, is that...
that's...
If you're not a good swimmer.
That's absolutely excellent. And you can get a weight to put around your waist, I've seen people use. So I would definitely recommend that. And it's really particularly useful for people who've more advanced arthritis, who find it's too painful to exercise. Some people might have bad feet, or their arthritis might have affected their feet in a way. So walking or running is just not an option for those, and they may not like a bike and they're not a swimmer. So any exercise in the water, because it's resistant based. There's a lot of good aqua aerobic classes that can be very useful for patients, and sometimes Arthritis Ireland used to run
we run physical activity classes. So I'd encourage anybody to look at our website, arthritisireland.ie, to find out more there about what might be available in your area, and indeed some of our classes are available online as well. So that's definitely something that people can tap into. As well, just the whole role, obviously, with exercise, and then we have diet. And that's obviously something that's always spoken about when it comes to arthritis. And what advice do you have? Because obviously there's, huge amount of literature out there, and there's probably a lot of false information, good information, and everything in between.
And people, I suppose most patients with rheumatoid arthritis are really wanting to help themselves, which is super, and it's really to be encouraged. And they often go to diet, which is a very natural thing, and I think that's really helpful and really useful and very, very much to be commended. There's so much information there which is a challenge. And that can be a problem sometimes, because sometimes I see people come in who've cut out loads of food. They've cut out dairy, they've cut out wheat, they've cut out meat, they've cut out acidic foods, so much. And before you know it, they've cut out very important food for their nutrition that they need. So and there's books, I've seen books about arthritis and diet, and you can spend a fortune buying all those. So really we have to go back to the evidence. So what we do know is a healthy, balanced diet is really important. Avoiding overly processed foods, too much sugar, they are probably aggravating arthritis, but within reason. You don't need to cut everything out. Life can be tough enough as it is. So I think in moderation, everything in moderation. Avoid excess alcohol, particularly for on certain medications. That would be important. And avoiding smoking. Now, I know that's not quite in diet, but just we do know certain people who smoke who have rheumatoid arthritis do worse, and that particularly if they're seropositive, we find that their response to treatment and the response to the condition are more negative. But back to diet, a lot of oily fish can be helpful, and vitamin D in their diet and sunlight is probably helpful as well. But we don't need people to be taking lots of extra supplements unless you need it for other reasons. A lot of people talk about the Mediterranean diet, which is, fish and vegetables, and there's a lot to be said for that. But I would say a healthy, balanced diet with avoiding sugar, processed foods, excess alcohol is the main thing. Now, I have had people who say, well, I've cut out tomatoes and I feel much better, and there's certain foods that people are known to be more acidic than others. I'm not so sure that we really need to do that. Now, people feel a lot better sometimes on doing it, and I'm not going to argue with them. But in general, a healthy, balanced diet with fruit and vegetables is better than overly processed foods.
I guess another part of that is appropriate, portion size.
Yes,
as well, because that's something that's crept up in recent years in Ireland. Portions aren't quite what they used to be.
Yeah, and linked with that is weight as well, and we it is difficult for patients with rheumatoid arthritis, and the most important thing is to get your condition under control and get well. But if you have excess weight on, it's going to be much tougher on your joints, particularly your knees, your hips, your feet, and for every extra stone weight you've on, that puts significantly, nearly 4 times that on your joints when you're actually trying to walk. So if you're trying to exercise and you've excess weight, you're just making things much tougher. So looking at your diet, and maybe it's very hard, patients say, look, if I'm in pain and I can't exercise, so just do what you can and maybe look at making small measures. Often it's best not to look and see what you can do in a week, but look what you can do over 6 months. So any small changes to keep.
I think it's small changes though, in weight. If somebody is overweight, isn't it? Small changes can actually have quite a big impact when you talk about maybe if you're carrying an extra pound, that's 4 pounds of pressure through your knees, for example.
Yeah.
So
and exactly, to turn that on its head from what I was doing. And so if you lose 1 pound, you gain nearly 4-fold that when you're trying to walk. So if you lose half a stone, it's nearly your joints benefit 4-fold by that when you're trying to walk. So small weight loss makes a big difference. And then the last thing on diet, really important to look at calcium intake. If you can get that through your diet, it's the best way of all. So we generally need 5 portions a day. So milk, a glass of milk, a matchbox size of cheese, 1 yogurt, that's all 1 portion. So that helps prevent osteoporosis if people who are, just because it's an extra risk with rheumatoid arthritis. So just to look at maybe when you are at your diet, and people who are trying to lose weight or have high cholesterol worry about that. So the low fat milk or skim milk or yogurts are often a good way to do it.
Still have the calcium.
And it's a portion size then with the cheese. Still have your cheese, but matchbox size is 1 portion.
Don't go overboard. Brings me to my last question, really, and it's really about looking to the future. You've talked about the many treatment options that are now available for people living with RA, and it certainly is a much more positive place, in 2023 than it was in decades gone by. In your opinion, what does the future look like for somebody getting a diagnosis now compared to 30 years ago?
Yeah, it's such so much more positive now than it was, and it's so, I suppose that's why I went into rheumatology, is because we can do something about it now. So years ago, rheumatology units were big rehab units because that's all that we could do, whereas now it's very much an outpatient speciality. And into the future, I think I would be hopeful that if we can predict earlier what drug will work for which patient, that will be the first step, I think, so that they don't have to go through that cycle of 6 or 7 drugs on occasion. And I think the other thing where a load of work is happening at the moment is preclinical rheumatoid arthritis. Is there a way we could capture people before they get it? And we're not there yet, but there is really good work going on it. And the whole idea is, I think some patients may have found that they went to the doctor 6 months ago with some niggles, wasn't picked up. Maybe in the future something could be picked up 6 months earlier, and that might prevent it progressing to this full symptom flare, and might mean that an early treatment might prevent need for lifelong treatment or long-term treatment. I would hope that that's the future. But I think first thing will be knowing the right drug for the right patient quickly, and I think there will be it'll be very clear to us. I imagine quite soon. I don't think we'll be waiting too long for that. But treatment for cure, I think will come, but I think it'll be a little bit longer.
And on that very positive note, I'll finish today's interview with you. Thank you so much, Dr. Carmel Silke, for being with us today. Much appreciated.
Okay, thanks very much. Thank you.
And thank you very much for watching. For more information on rheumatoid arthritis and other arthritis diseases, please log on to our website, arthritisireland.ie. You can also get further information via our online Facebook groups or via our helpline on 0818 252 846. Thank you again to Dr. Carmel Silke for joining us today and for her insights and experience. We look forward to seeing you again soon.